Okay. Are we all set? David, should we start?
Yes, let's start. I think it's already time.
Yeah, so very short case today. Um, I'm going to present to you the case of a 23-year-old male who presented to me at the OPD clinic with multiple joint pain.
Okay, so let's start. Then, Joseph, can you help mute Walter speaker so we can follow closely? I'm not sure if uh, oh yeah, that's good. Okay, so a 23 years old male with multiple joint pains. Okay, multiple joint pains. I think joint pain is a familiar complaint. Although I cannot say I'm confident enough. I do not think I know enough to be very confident about joint pain. But so the way I think about joint pain is there are multiple etiologies of joint pain, and uh, the number of joints involved, I think, helps in a way. So maybe just before we proceed, I can just throw in some differentials and narrow down as we go, because it's just the beginning. We just had the chief concern, and therefore uh, not yet aware what exactly is going on. Okay, so joint pain could be due to anything. So for one, it can be an infection, for example, but then, as I say, the number of joints involved is very crucial. So multiple joint pains being infected at the same time, I think that is less likely. But then someone can have joint pain and swelling because of an infection. Another thing is we can also think about autoimmune diseases. We know rheumatoid arthritis, systemic lupus erythematosus, and many other autoimmune diseases uh, can cause joint pain. And then you can also have joint pain because of crystal deposition diseases like gout, as well as pseudo gout. And then, so crystal deposition diseases, infections, autoimmune disease, trauma. Yeah, so I think at this point it's still very general, and therefore there are some things that will help me narrow down, because one of the very important branching points is to know the number of joints involved, and then to know if the joint pain that we are talking about, are we talking about an arthritis, which means uh, there is inflammation. So there is that joint pain is inflammatory or not, and there are some distinguishing features. So I think more history will help me get clarity, and I can discuss the differentials better after hearing the HPI. So let's proceed.
Okay, thank you very much. So we proceed with HPI. So patient reports that 2 years ago, he experienced gradual onset of pain and swelling of the left wrist joint, and which was followed by involvement of the left ankle, then the right wrist joint, then both knees, and lastly the right ankle joints. He reports to have experienced pain and swelling of the third left finger also. He also reports that pain is persistent, but swelling has been on and off. The joint pain requires NSAIDs, but paracetamol cannot calm the pain. He also reports a significant weight loss of 65 kg from 65 kgs in 2022 to 55 kgs in 2024 when I was seeing the patient without a change in diet or increase in level of activity. He also reports a morning stiffness that lasts for more about 1 hour, and he has been attending multiple hospitals upon this presentation and told me he was told to have a low blood level than normal. But he doesn't report any back pain and he denies history of fever, night sweats, cough, painful urination, urethral discharge, eye pain or eye reddening, and rash. That's HPI.
Let me see the first slide. Thank you. Yeah. So this is I think this is helpful, but it's still a difficult journey. So the beginning of this joint pain seems to be it was asymmetrical at the beginning, and I'm not sure if we can establish symmetry towards the end. Let's see. But the pain started with the swelling. So there's pain and swelling of the left wrist joint, and then left ankle, and then the right wrist, and then both knees, and then the right ankle. So I think up to this point we are talking now. I'm not sure, Joseph. Is it uh, when the left ankle was involved, and then later the right wrist, and then both knees and the right ankle? Is the pain on the initial joint still there, or it recovers and moves to another joint?
It was still there.
It was still there.
Yeah.
Okay, so what I'm trying to establish there is the pattern of this joint pain, because characteristics, of course, I'm not sure if we can say it can absolutely help you make a diagnosis, but at least it helps in a way. When we talk of joint pain, there is joint pain that is migratory. I think when I say migratory joint pain, we have some thoughts. For example, acute rheumatic fever we know presents with migratory joint pain. But then, of course, I think it's unlikely to talk about acute rheumatic fever, which lasts for 2 years. But then we have another pattern of joint pain, of joint involvement, which is additive. So you have pain which starts in one joint or in a single pair of joints, and then it involves some other pairs. So this sounds to be additive, but the onset of this pain was asymmetrical. There was no symmetry. But then at least I think we have around 3 major joints involved. Bilateral, you mean the both wrists are involved, both ankle joints as well as both knees. And then there is also joint of there is pain and swelling of the left finger. So there is a number of joints there involved, and then I see some features which are to some extent they are telling me, okay, most likely that increases confidence that the joint pain that we are talking about, there is actually inflammation going on. And I know when I talk about pain and then mention inflammation, it can be confusing, but then you can have pain without inflammation. Of course, we talk about pain as a feature of inflammation. The cardinal symptoms and signs of inflammation, we talk about pain, color change, loss of function, and then heat. But then you can have pain without inflammation. For example, in osteoarthritis, that is osteoarthritis is, of course, it's an arthritis, but then a non-inflammatory arthritis. It's more of mechanical. Or you can have periarthritis, or you have pain in a bursa or in a ligament, but then not involving the joint. So I think to most likely we are talking about inflammatory joint pain, or we can say we are talking about an arthritis, because there is pain, there is swelling. And then we also hear some other features which are uh, we could attribute to inflammation going on. There is a significant unintentional weight loss. And then this pain um, is relieved by NSAIDs. Okay, any pain can be relieved by NSAIDs, but I think pain and swelling are telling me we are most likely dealing with an arthritis rather than a periarthritis. And then can I see the next slide? Okay, and here is another thing that it is associated with a morning stiffness that lasts more than 1 hour. Again, another feature of the arthritis that we are talking about, inflammatory arthritis. Um, and then this patient was also told to have a low blood level than normal. Okay, so I interpret this as anemia. So the patient has inflammatory arthritis. So it's I think I can call this a polyarthritis, although the cutoff varies depending on which reference you use. But then, so some will tell you that if you have 3 or more joints, that is a polyarthritis, and then 3 or less, that is an oligoarthritis. So maybe I may not be very correct on this, but I take it to be a polyarthritis. So you have an inflammatory polyarthritis associated with morning stiffness, which lasts more than 1 hour. And then the patient is having anemia. And then the patient also has significant unintentional weight loss. But then no fevers, no night sweats, no cough. Dysuria, urethral discharge are important here because reactive arthritis is commonly it's a monoarthritis or an oligoarthritis. You can have a few joints involved, but then um, I mean, this is not in keeping with the reactive arthritis because it's commonly an oligoarthritis or monoarthritis. But dysuria and urethral discharge, those were important. But then eye reddening, eye pain, this is also important because there are some arthritis which are involved with uveitis, especially arthritis, ankylosing spondylitis, and many others can be involved, can be associated with uveitis. But then, of course, the absence of uveitis, I think, does not completely rule them out. And then a rash, of course, if we are thinking about autoimmune disease, it's important to ask about a rash. So I have a number of thoughts at this point. I think I will most likely lean on the side of an inflammatory polyarthritis, and in that one, I think I'll think about the category of uh, autoimmune conditions like SLE, like rheumatoid arthritis. Of course, the age of the patient at 27 years, 20, is it 27 or 23 years old male?
23.
Okay, 23. So, I mean, there's a number of these conditions that does not fit perfectly, but I think that is the line that I will take. But at the same time, I'll still be open to other considerations. So more details while I process it.
Yeah, thank you very much. So we proceed, and next slide is the review of our system, which was not significant. The GI, CVS, neuro were all normal. The past medical history, the patient in the past medical history category, oh, he attended where I was because he was being diagnosed with gout arthritis based on this presentation, but he had no previous surgeries. And meds, so he was put on allopurinol 300 milligram OD for like 6 months now, and he was on as needed meloxicam. Also, he was on chondroitin glucosamine. Family and social history: he was sexually active with with his girlfriend with inconsistent condom use. He doesn't smoke or drink. There is no family history of joint pain. And his mother, his father, and his siblings are all alive and are healthy without any diseases.
Okay. Thank you. So I'll spend some time on the past medical history and the diagnosis of gout. So what you've been presenting is a 23 years old male with about I think a 2 years history of joint pain, which has started with one joint, but then it was additive, involved other joints. This patient is experiencing morning stiffness. The symptoms are long-term, relieved by NSAIDs, but the patient uses them regularly. Of course, I gouty arthritis. We know it's thing. So gets flares. Someone gets flares, and commonly, when we talk of gouty arthritis, again, it's of course when I talk about inflammatory arthritis, it falls in that category. But based on the number of joints involved, I think that makes it that makes it unlikely. Why? Because gouty arthritis is commonly a monoarthritis or an oligoarthritis again, although yes, I cannot remember internalizing that very well, but patients who have had multiple attacks of acute gouty arthritis, so some of them can end up with joint pains which are almost chronic. But if we talk of gouty arthritis, the commonest presentation is a monoarthritis, and of course it's an acute thing rather than something long-standing like this one. So I think this diagnosis of gouty arthritis to me is I think I'll have to. I'm still looking for something which better explains the symptoms of this patient rather than the gouty arthritis. And then medications. So medications, the patient is on allopurinol. I believe it's because of the gouty arthritis that the patient was diagnosed with. And yes, many people can have elevated uric acid levels, and I believe many of us have come across that controversy. It's a huge debate. It's a huge debate among clinicians whether to treat hyperuricemia or not, and that includes asymptomatic hyperuricemia. And then I think it will be very confusing, especially for this patient who is presenting with joint pains. I think someone might be convinced that maybe the uric acid levels, maybe he was found to have elevated uric acid levels, and then someone decided to treat them. So, but I think uh, I still need to look more rather than take this diagnosis of gouty arthritis. So other medications, glucosamine chondroitin, it's a medication people use to treat, especially so people who present with long-standing knee pain. They are diagnosed with osteoarthritis. They are kept on that, and I think one of the theories is that at least it helps increase um, the synovial fluid, but I think the effectiveness is questionable in literature. So the absence of a family history, because parents and siblings are all doing well, and this patient presented with joint pains. I mentioned about spondyloarthritis, so some of those can have a familial tendency. Because there's some genetic component, some forms of HLA antigens are associated with spondyloarthritis, and therefore it can have there could be a familial history, but then absence does not completely rule them out. So I think I'm still at the same point. So let's hear the exam as well as the labs, so I can see if I can make any progress.
Thank you very much, David. Yeah, truly, as you're saying, gout arthritis, monooligoarthritis, but I believe you have come across what is called a polyarticular gout. Can it present like this?
Well, so that's what I was talking about initially. That uh, in my previous reading, I've come across patients who are known to have had some attacks of gouty arthritis, who are presenting with joint pains chronically, but then uh, a presentation like this one, I think I'm yet to experience it. So I'm not exactly sure.
Sure. Okay, so let's go on. And this is the exam. So patient was alert, he was a febrile, he was not pale, not jaundice. He had bilateral axial lymphadenopathy, which were single on each side, firm and non-tender. He also had nodes in the medial arm bilaterally, which were subcutaneous. They were also single on each side, they were firm and they were non-tender. He had no rash, no lower lymphedema. Vital signs were within normal limit. Musculoskeletal system exam. So the joint exam, he had tenderness in the proximal interphalangeal joints, metacarpophalangeal joints, both wrists, ankles, and knees bilaterally. So he also had disfigured knees, disfigured wrist bilaterally, and he couldn't flex or extend them completely. For abdomen, chest exam, cardiovascular exam, and neuro were all normal.
Okay, yeah. So let me see this slide again on the general exam. This is interesting, and I'm trying to think. You were very specific and categorical that he had a bilateral axillary lymphadenopathy. So okay, this is interesting. And then the patient has nodes. So I'm thinking, okay, especially in the axillary area, uh, you specifically say there were lymph nodes. So I think I can leave it that way, that there are lymph nodes. Now all I'm thinking of is what is going on in the lymph nodes, and what exact pathology are we talking about that causes multiple joint pains, that causes a polyarthritis? Because at this point, I think the confidence that we are dealing with the polyarthritis increases. But then the nodes that you are talking about in the medial arm bilateral, subcutaneous nodules, which presents or can present in patients with rheumatoid arthritis, of course, many times when it is long-standing. So the lymph nodes, I'm yet to figure out what is going on. And then the next slide. Okay, so musculoskeletal system examination is what increased my confidence that we are dealing with the polyarthritis, because if you count, I think this is, we can agree that this is more than 4 joints, actually many joints involved. And then the patient is also having disfigurement. So whatever is going on is an arthritis that is very erosive or very disfiguring. And one of the things I can think about quickly is rheumatoid arthritis. But of course, given his age, rheumatoid arthritis proper maybe doesn't fit very perfectly. So that makes me think about juvenile rheumatoid arthritis as one of the possibilities. But then, of course, the other arthritides that I mentioned earlier, I think they still stand. So That's the progress I've made so far. I think it's just increasing the confidence that we are dealing with a polyarthritis, which is symmetrical. And when I talk about a symmetrical polyarthritis, those are the differentials we're talking about. So no changes. I mean, uh, gout, gout have at least. So I'm open to learning something new today. But gout presenting with the symmetrical polyarthritis, I think that is very unlikely for me, at least to have read or experienced it in real life. And again, of course, the other differentials that we talked about that present with an oligoarthritis or a monoarthritis, I think those are less likely in this patient. So we talk about reactive arthritis, gouty arthritis itself, but again, some spondyloarthritis also present with, for especially when we talk about, because spondyloarthritis, there is axial and there is peripheral. So a peripheral spondyloarthritis can present with joint pains, but then it's commonly an oligoarthritis. And then, of course, talking about infections, if you are talking about infective arthritis, commonly we expect that to be an oligo. I mean, more commonly a monoarthritis. So uh, asymmetrical polyarthritis, rheumatoid arthritis, SLE, so the same pathologies that we were talking about earlier. And then, of course, you have many other conditions that are associated with them, but then we do not have enough features to say, okay, maybe this is not in that category of rheumatoid arthritis, for example, SLE, and then start talking about uh, inflammatory myopathies, which do also present with the polyarthritis, but then we would expect some muscle features or dermatological features. So that's where I am up to this point. So I believe you have some labs and other tests. Maybe they can help me make progress.
Okay. Here are the labs. Uh, Not impressive. White count was normal with normal differentials. HB was normal. Platelets also. ESR of 8 normal. Creatinine BUN normal. Only uric acid was raised at 476. Machine's upper limit of normal was 431. Liver functions and enzymes were normal. Rheumatoid factor was negative, and his urine analysis was also normal. This is the X-ray of the bilateral knee joints that I found in the system. If you can see anything in this.
Okay, so I will rely on you to give me if there was a proper radiological report. But then when I look at these joints, I'm not sure if it's artifacts or anything. But then, of course, if I look medially on both joints, I see that the joint spaces are almost preserved. But then uh, a little bit laterally, but not on the far lateral side, I see that there's joint space narrowing, but uh, I do not see the sclerosis or the bone lysis that we see in conditions like rheumatoid arthritis. So I'm not sure if it's the quality of the images or not. So I would need a proper radiological report from you if there was any.
Yeah, so radiologist said they were normal. The radiologist said they were normal,
Okay.
and we believe him. And also, I did an ultrasound abdomen, which was also normal.
Okay, so I'll go back to these labs. We were told the patient initially was told to have low HB than normal, but we see the HB here is 12.4. Anyway, so it depends on where you are from and the cutoffs that you use. If we are talking about people of the West, for a male, this would be anemia because I think they use a cutoff of 13. But I believe in our setting that is normal. So no anemia. And what's interesting is the ESR is normal. The ESR is normal for this patient. So we are talking that most likely we're dealing with an inflammatory polyarthritis, and it's not uncommon for the inflammatory markers to be elevated in these conditions, but then ESR is normal in this case. So the uric acid, I believe we've already talked about it. It's a mild elevation in the uric acid, and elevation in uric acid levels are not an unusual finding. I mean, you can have many people who have elevated uric acid levels and they do not have any symptoms. And even if we are talking about this patient's presentation is not in keeping with gouty arthritis, as far as I can tell. And when someone has an acute attack of gouty arthritis, many of them commonly actually have normal uric acid levels. And there are some theories around that the inflammation, I think, when the interleukin levels are high, I don't know what happens, the uric acid levels go down. So you can have someone with an acute gouty arthritis, but the uric acid levels are normal. So that does not mean the patient doesn't have an acute gouty arthritis. But this patient's presentation, I believe it's not in keeping with that. But then rheumatoid factor being negative. So rheumatoid factor has a sensitivity when you are talking about rheumatoid arthritis. The sensitivity of rheumatoid arthritis is about 80% at least. That's the sensitivity. So if someone has rheumatoid arthritis, it's 20% of patients who can present with a negative rheumatoid factor. So a positive result would increase our confidence to a certain extent, but remembering that rheumatoid factor is not very specific, and therefore we would need to do something like anti-CCP. But then it being negative, it does not completely rule out rheumatoid arthritis. If you read around those markers, if someone has a presentation that is consistent with rheumatoid arthritis and rheumatoid factor is negative, it does not rule out rheumatoid arthritis. But then, so I think this is where I need to do more reading, because I'm thinking around inflammatory polyarthritis, and on top of my list are things like, given the age of the patient, juvenile rheumatoid arthritis, and then something like SLE, given the sex of the patient, that makes it less likely based on that. But again, if I try to fit in the criteria, I do not see enough criteria to talk about SLE, because I think the only thing that we have is an inflammatory polyarthritis. We do not see hematological features, at least from this, no skin features. So I think rheumatoid arthritis is more in keeping with that than SLE, and therefore a negative rheumatoid factor, I think it does not completely rule it out. But then I think I have to do more reading now. If I'm talking about juvenile rheumatoid arthritis, to familiarize myself with it more, and to see the test characteristics of rheumatoid factor in that specific condition, if it's the same as the rheumatoid factor that, as the rheumatoid arthritis that we see in the adult population, or if it presents differently as far as rheumatoid factor is concerned. So, another thing is, you say the patient has a disfigurement on the wrist joints, I think. So I would be very much interested to see the radiographs of those joints. And yeah, I think that's where I am now. And there is something else that I have not been able to explain up to this point, and that is the axillary lymphadenopathy. I'm thinking because it was very specific that it is lymphadenopathy, and then the others I think were nodules. So what conditions present with asymmetrical polyarthritis and then lymphadenopathy? I think I'm still yet to explain that, and that could be a signal to the diagnosis which I'm missing, but I'm open to learning that today. So anything else that you have?
Yeah, it's unfortunate that we didn't take the X-rays of the wrist, which was extremely important, by the way. So yeah, what you do? Will you do lastly now?
Okay, so um, I talked about anti-CCP, but then what I'm thinking of is, okay, are there specific markers for juvenile rheumatoid arthritis, for example, uh, which I'm not aware of? So I think this would be a point where I go online on a resource like UpToDate and review quickly and see if there is anything else that is important to be done in this patient in order to help me arrive at a diagnosis. But at the moment, I'm thinking about anti-CCP. I'm not sure if that can help us make progress. And of course, uh, if both of them are negative and this presentation is in keeping with rheumatoid arthritis, I think I would say, okay, this is one of the possibilities is we are dealing with seronegative rheumatoid arthritis, of course, juvenile rheumatoid arthritis, but then I am not very confident with that diagnosis. So I think I'll need to go and read more and see what am I missing that explains the patient's presentation.
Okay, so the anti-CP, of course, was sent outside. Those who came back positive. Does it change anything that you're seeking?
Yeah, a positive anti-CCP changes, increases my confidence that we are dealing with rheumatoid arthritis. Why? Because anti-CCP has a lower sensitivity than rheumatoid factor. I do not remember the exact numbers, but it's very specific for rheumatoid arthritis. The specificity is more than 90%. I think we're talking in the order of 96% or more. So, and of course, uh, these autoimmune markers should be ordered and should be interpreted in the setting of a consistent or yes, a consistent clinical presentation, because if the clinical presentation is not in keeping with the rheumatoid arthritis, for example, a positive rheumatoid factor is useless, because you can have positive autoimmune markers in patients who are completely healthy. So if you are not thinking, or if your patient does not have a presentation that is in keeping with an autoimmune disease like SLE, for example, you do not need to order ANA.
No.
So given the patient's clinical presentation of asymmetrical polyarthritis, the nodules, I believe those are nodules that we see, the deformity that we heard about on the wrists, that is a presentation that is in keeping with rheumatoid arthritis. So a positive anti-CCP increases my confidence, not exactly to 100%, but I think it's good enough to start treating the patient for rheumatoid arthritis. So that's my thinking at this point.
Yeah. So yeah, that's very nice. You say um, the specificity of anti-CCP is above 90%, which means it's not 100. Is there a chance that it can be?
Yes.
Is there a chance that it can be a false positive, and we are dealing with some separate entity from these rheumatoid stuff?
Uh, that's very possible. That's very possible, and I think so. Another thing that I would need to do is is to read on what else can give us a positive anti-CCP that is not rheumatoid arthritis. It could be, but then when you talk about diagnostic reasoning, if so, I mean, a consistent clinical presentation and then a positive test increases. If you are thinking that my possibilities may be above 90%, I think that is good enough to start treating. But then, of course, we should always bear that in mind, because if at the end of the day, for example, I start treating the patient and then the patient doesn't respond, or the patient worsens well on treatment,
Mm.
I'll have to step back and think, okay, maybe the disease is aggressive, maybe it's not the correct dose of the medication, or maybe we are dealing with the wrong diagnosis. So I think we should always be open to the possibility that the diagnosis we are working on is not the real diagnosis, and try as hard as we can to think about what else could explain the patient's presentation.
Hmm.
So it could be, but given the patient's clinical presentation, I think it's good enough to put that as our working diagnosis and to start treating the patient.
No. Yeah, that's very nice. And I have heard you mention this juvenile idiopathic rheumatoid arthritis. Are we leaning on that direction, or are we saying just rheumatoid arthritis?
Okay, so this I think that is where I will not I'm not very confident to say, because when we talk about rheumatoid arthritis, commonly the peak the age, or the age of peak incidence of rheumatoid arthritis is way beyond adulthood.
Mm-hmm.
I cannot remember the exact numbers, but you are talking more than 40s, I believe 50s onwards.
Yeah.
So a 23 years old presenting with a presentation that is consistent with rheumatoid arthritis, uh, just the age itself, I think, is what makes me say, okay, maybe this is not the proper rheumatoid arthritis we are talking about. Maybe it's juvenile. But then again, juvenile rheumatoid arthritis, oh yes, GIAs, the most proper terminology is GIA, juvenile idiopathic arthritis. The peak age is actually the teens, and this patient is beyond the teens. So you are talking about so it's in the second decade of life, in the teens, and this patient is above 20. So it's kind of a gray zone. So I'm not exactly sure where to properly put this patient. Are we talking about rheumatoid arthritis or juvenile idiopathic arthritis? So I think I'll just wait to learn that from you.
Mm-hmm. No. Thank you very much. So, yeah, I had some thoughts like yours, and the age is something which made me like think, should I change my diagnosis? What? But yes, at the end of the day, I diagnosed the patient as just saying rheumatoid arthritis, and so what I did, I because the patient presented with pain on that day, started on him on prednisone 20 and tapered it down and stopped it later. At the same time, I started on methotrexate at 7.5, but it didn't respond. I raised the dose at 10, and then pain subsided. Also, I gave folic acid because to avoid the side effect of MTX. And we were in communication with this patient. Now it's like 6 months, and then he is so thankful he's never experienced any other pain. But yeah, I appreciate that what you taught us here from the beginning, that when we see joint pain, the most important thing is the number of joints, whether it's mono, oligo, or poly, and then the types of joints, small, large, plus are they inflamed or non-inflammatory. That is, if you do that, I think most of rheumatology is done. And very important thing you said, it can be acute rheumatic fever based on the presentation, but The tempo of the disease doesn't reflect a 2 years cause or acute rheumatic fever is unheard of. And then you describe this as a additive pattern, saying that rheumatoid arthritis usually is symmetrical. Yes, but the literature is that when it starts, it can start as symmetrical, uh, as asymmetrical, sorry, as this patient did. And he told us that to differentiate whether there is just arthritis or arthritis, is there inflammation or not? Pain plus swelling means there is inflammation. And again, you discarded the diagnosis of gout that was made before in this patient, which of course made it delayed the management, the proper management in this patient. That gout is usually mono or oligoarthritis, and even if it's polyarticular gout, should have been a chronic form of gout. Later, it can be a polyarticular gout, and gout has pain-free episodes. Someone gets sick for a week, and they're free for 6 months. They get sick again. It doesn't matter how much uric acid they have in their blood. Yeah, rheumatoid factor sensitivity 80%, very true. Which means if it's negative, it's not the end. And very important thing is how to order the autoantibodies. You think first of the pretest probability. To whom are we ordering this thing? For example, if you go in the community and you order rheumatoid factor to everyone, some normal like 4% of normal people will be positive, like 5% of normal people if you order ANA, more in women by the way. 20% sorry, which is 1/5, not 5%. Yeah, so that's very important. So the issue became from the juvenile idiopathic arthritis. I saw your point there, very important. That first of all, this thing is most common between 1 and 5 years, and when it is beyond 16 years, it shouldn't be called juvenile rheumatoid arthritis. The name changes into what is called adult onset Still's disease. But this disease never, it doesn't look like that because you have a triad of things: a salmon colored rash, fever, very high fever, and then the arthritis. So this patient couldn't get into that adult onset stills. And so what are we demanding with? At least disfigured joint, systemic symptoms, small joints plus some large joints, rheumatoid arthritis, as you correctly said. I have my teaching points here. So yes, if you read David, you read the up to date, the epidemiology, the edge is said to be in the elderly. But I listened to a podcast that in the Cabsiders, and that expert said it's usually bimodal. There is this 20 to 40, and on the other end there is the elderly, and these 20 to 40 mostly are females. But this guy here was a male. So as any other autoimmune disease, rheumatoid arthritis also is 2 times more common in males than in females. They can have systemic symptoms like fever, fatigue, weight loss, which this patient had weight loss. And the typical joints to be involved include the metacarpopharyngeal, the proximal interphalangeal joints, the wrist, the metatarsal phalangeal, and other joints. The exoskeleton is also always spared. Maybe there can be involvement of the C spine, but that's so late in the disease. So there can be a exarticular involvement, like anemia, which this patient have, testicular lung disease. They can have subcutaneous nodules, which I think in the medial aspect of the arm, this patient is what they have. They can have lymphadenopathy because they have inflamed joints, so the lymph nodes are reacting to that. They can have a splenomegaly, which will be called a Feltis disease. And the diagnosis is usually clinical. It doesn't matter what serology is saying, but you do serology for confirmation. But even if they are negative, as David said, you can have a seronegative rheumatoid arthritis. But at that point, you should be very suspicious. Maybe you are wrong. And if you have your friend who is a rheumatologist, send that patient to them. So the rheumatoid factor sensitivity 69% with a specificity of 85%. So lots of false positive. And anti-CCP sensitivity 72%, like rheumatoid factor, but the specificity is very high, 95, 98. And you do, if you do both of these and they are positive, the specificity of the it to be rheumatoid arthritis rises to 98%. So treatment can be non-pharma, which is exercise and counseling, and pharma. You should start DMARDs as fast as possible, and this include methotrexate, easily available, sulfathiazine, hydroxychloroquine, leflunomide, and other biologics. So NSAIDs and prednisone are used for pain, and you should taper them down and stop them, because if you put this patient on DMARDs, they have to be free of pain. Yeah, thank you, David. That is all we had for today, and thank you, Irene, for reminding us of the juvenile rheumatoid arthritis, 16 years of age. Any reflection from you, David?
Yeah, thank you very much, Joseph, for the case. I think, Joseph, we've done a number of cases involving joint pain, but I should say this was one of the most intense. Uh, yes, it's one of the most intense, and that's what keeps reminding me and humbling me that medicine is a never-ending journey of discovery and learning. Because as much as I could think, okay, I've seen or I've discussed a number of joint pain cases, and therefore I can say that I can confidently discuss it or get the diagnosis right. I think this was one of the most challenging cases of joint pains. Yes, I mean, the approach to the number of joints involved and everything else were very much in keeping. But then you come to epidemiology, which is one of the key features in making a diagnosis, because you are talking about what is the syndrome, who is the patient in terms of the age and the sex, and then you come to find, okay, this presentation fits a certain syndrome, but then the demographics of the patient do not seem to fit. So I think that is what humbles us every day and reminds us that we need to keep learning, because medicine is a never-ending journey. So I thank you very much for the case. I believe I have some things to go and revise.
Sure. Okay, thank you. So, do we have anyone a question or another reflection from the audience, or like an experience, or did we get the diagnosis wrong, the two of us? If you think you can challenge us, please. Yes, Clara.
Um, Thank you so much for the presentation, Jose and David. Again, I think we needed this concerning the fact that we see a lot of patients with rheumatology, but most of the time there is issues with misdiagnosing these patients, and issues of investigating them. For example, I'm not sure, Jose niambie, kuna mgonjwa, there's a patient I sent for Anna and Anka. I think you'd have to send them outside or something.
Yeah.
So those are the issues that we have. But then again, I wanted to comment on few things based on the presentation. I saw in the history we had a place where you ruled out uveitis, and I was thinking of at that time. I think Devi explained on reactive arthritis. I think you missed reactive arthritis also. So in reactive arthritis, we have the mnemonic of can't pee, can't bend the knee. So I think you are ruling out reactive arthritis in that patient. But then again, I think we had an issue with anemia in this patient. You told us he has been having anemia. I just wanted to know, like, did you get to know what was the HB of the patient?
Yeah.
Yose.
Yeah. Thank you very much, Clara. So no, because when I did the FBP at my hospital, it was normal. But he told me when he attended somewhere else was told he has anemia, so I had to bring it here also.
Okay, so probably it was not severe anemia. Maybe it was a mild to moderate anemia, something like that.
Can be.
So again, with the issues of anemia, I had a thought of inflammatory arthritis, but then we have a lot of other autoimmune arthritis that could present with systemic symptoms such as anemia. I think you've described them very well. But then I had an issue with anti-CCP positive. I think that's where you had to question Devi, whether if you can think of the possibilities of other arthritis with anti-CCP positive. So I recently had a patient who had similar presentation, same age, I think about 25 years old, a male. But this one, it was X-ray was suggestive of rheumatoid arthritis. Before even we went for investigation, he had the osteopenic lesions, and you could see them. I think you would see them more distal to the joints than proximal. Yeah. So, but then we did the rheumatoid. It was negative. We went for the anti-CCP. It came back positive, and I initiated treatment. But then I also had questions. What if it's anti-CCP positive and it's not rheumatoid arthritis? So I went back reading about these rheumatology things. And then I found out that you could have, a patient could have mixed connective tissue disorder with anti-CCP positive. It could. It's not common, but it could happen. So for this condition, you need a further serological tests whereby you'd need to do the anti what is this anti RNP antibodies.
RNP, that would be,
Yes. So again, I have not seen the patient again. I'm expecting him to come back after a month. I don't know if we can do them in Tanzania, but then those are the issue. Also, I had issue with SLE. I read that SLE, patient can have SLE with overlapping rheumatoid arthritis. It's not common, but it can happen. This patient have SLE with overlapping rheumatoid arthritis, and they can have anti-CCP positive. But then you have to do some other tests, the ANA, the anti-DS, double-stranded DNA, and of course the complement levels. So yes, I saw the one that you discussed, Jose, the adult onset still disease. I think we had a discussion on it some other time in the group. You will expect this patient to have a rash on the extensor surfaces, whereby you'd rule out that this patient has adult onset still disease, because sometimes they can also present with the anti-CCP positive. And then the reason why I asked about the HB of the patient, I saw in your investigation the HB was normal. It was 12.7, but then you mentioned about anemia. So in my mind, as the time you're presenting, I was thinking it could be infectious, chronic infections like TB, HIV. You would expect this patient to have they can also have some sort of, they can mimic autoimmune disease like rheumatoid arthritis or SLE. So I was expecting, I don't think if you did the HIV screening for the patient.
Yeah, it was negative.
But then again, it was negative. But then again, we had the ESR was normal. It was not in keeping with TB again. So, but then if at all the ESR was high, which you would expect, or the CRP was high, which you would expect in rheumatoid arthritis also, you would need to further investigate with the issues of weight loss, although it was not significant weight loss, because coming to think about 5 kgs in 2 years, you cannot really, it cannot be in keeping with significant weight loss you'd expect in TB. So there were the issues where I read that these are the patients who would need the famous IGRA test. So yeah, so those are the issues. But then again, thank you so much, David, for explaining the presentation, because sometimes you'd see these patients and you would expect to have a clinical judgment more than rely on the labs.
Yeah.
So you treat them based on their clinical presentation.
Yeah.
So I think that was the most important part. Thank you.
Yeah. Thank you very much, Clara, and appreciate your knowledge on the overlap syndrome and the mixed connective tissue disease. Yeah. Thank you, David, or anyone.
Ye- Yes, Joseph. So thank you, Clara. I think you've added a lot of knowledge to us on what can present with a positive anti-CCP that is not purely rheumatoid arthritis. But I think with your patient, you can be confident that you are dealing with rheumatoid arthritis if there is nothing else that is, because when we are talking of mixed connective tissue disease, our patient should have some features of an overlap syndrome. For example, we are talking about rheumatoid arthritis and then SLE and maybe something else like systemic sclerosis or Sjogren's. So if it's purely an arthritis, then you have at least many percent of confidence that you are dealing with pure rheumatoid arthritis. But if there was something else that in addition to the rheumatoid arthritis is pointing to another autoimmune disease, then I think that meets the threshold for suspicion that we are probably dealing with a mixed picture. Yeah. I see Irene has her hand up. Irene, karibu.
Oh, yes. Thank you. Thank you, David and Joseph. And thank you, Kara, for the comments. Joseph, at some point in time, I think my internet had an issue and I was out of the Google Meet. I wanted to ask if you had commented on the lymphadenopathy, and I would like to hear you again about that. And so alongside that, I wanted to ask you, is it a common finding in patients with rheumatoid arthritis? And if not, should we also start thinking of the possibilities of other lymphoproliferative disorders that might be associated with rheumatoid arthritis? But rather, the CBC, of course, would have started also to give us a clue, which was rather uneventful. I wanted to hear again your comment on the lymphadenopathy. How common is it? And could it raise a suspicion of lymphoproliferative disorders that could happen in patients with rheumatoid arthritis?
Yeah.
Yeah.
Thank you very much, Irene, for noticing that. So, yes, that's very true because, first of all, every time I see a patient with rheumatology, I keep going back reading and realize these very hard things. And so I didn't know. I've seen patients with rheumatoid arthritis. I didn't know, and I didn't think of lymphadenopathy as one of the things. And upon just googling, it came up very large percent. I forgot the percent, but it's very large and it's common. And the mechanism is just like you have inflammation, for example, in the small joints of the hand. So the nearest lymph node are the axillary, which is the most common site of lymphadenopathy in these patients. So yeah, that was it. So it is common.
Oh, so the lymphadenopathy is predominantly reactive in nature?
Yes, it is reactive, how they say.
Okay, thank you.
Yeah. So I think there is no one else. I love this, and it's already above the 1 hour mark, and I think we should close. But one thing is just
Yes, so Joseph, before you close, I mean, I know there were some weeks when I was a little away. I'm not sure if Dr. Wafundi had a time to say hi at any point in time. I see he has been frequenting here a number of times. So I'd love very much today to at least hear a hi from him. Hello, Dr. Wafundi. If you are in a place where you can unmute and say hi to the group, very much welcome.
Oh, I hope I've tried to unmute. So I'm following the discussion. my internet is not very good. I got cut off, just like Irene said. Trying to really follow the cases. They're quite interesting, and asking myself if I could do better than David. So this, I think you should go on. Yeah, I always try to attend whenever I can. But yeah, good job, and it just reminds us how to be humble about medicine.
Yeah.
So vast. You need to know a lot. You need to read and update yourself every now and then. And this is a typical example of a case that you can't really pinpoint good points towards rheumatoid arthritis. I got the feeling from the start that it's gonna be something rotating around rheumatoid. But again, yeah, negatives are there. So yeah, keep up the good work.
Thank you very much, Dr. Afundi. I think we are eagerly waiting for a day when Joseph or me will present a case to you, so people can gather some wisdom from you. So we are waiting for that day.
Hopefully soon.
Thank you very much.
And thank you,
Thank you.
and thank you, Dr. Afundi, for noticing no one can do it better than David. Yeah, so if there is nothing else, I think we should close. Good night, everyone.
No,
Yeah.
I wanted to say to Dr. Afundi, you are missed. It's good to have you here.
I try to hook on every weekend, but sometimes I can't. So yeah, I miss you too, guys.
Thank you.
Thank you very much, and I also see Dr. Mukiza in the crowd. Thank you very much for joining us. So I think if there's nothing else, we hope to. We are looking forward for the crowd to get bigger and bigger. But we hope for everyone who joined us today, we'll have you back next weekend. So let's keep learning and sharing knowledge. Thank you very much, and I think I'll let Joseph close if he has anything else, and if nothing, have a good night, everyone.
Good night.